Good evening, everyone. I am Arpita from the IGCP group, and I warmly welcome you all to today's insightful session organized to observe the Breast Cancer Awareness Month. Today, we will be delving into a very thought provoking topic, which is precision in prevention, judicious use of screening tools in breast cancer. It's my privilege to introduce our host for the evening, Dr. Sharda Jain ma'am. She is the Secretary General of the Delhi Gynecologist Forum and is the chairman of the North India Gynecologist Forum. She is also an esteemed expert of the Ethical Committee of the National Medical Commission for the past 6 years. With a vast experience and visionary outlook, we are truly fortunate to have her lead this very important conversation today. Over to you, ma'am.
Uh, Thank you, Arpita, and we are always obliged to you people to give us a national platform. So, welcome each and everybody who is watching us. October is a great month. It's a month of breast cancer awareness. As you all know, it is number one cancer as far as a woman in our country is concerned. It has surpassed cancer service long back. What is the peculiarity of cancer breast? Now, what we find is that lifetime risk of anybody who stays in India. Earlier, it was thought 1 in 8, but now it is much less. 1 in 22 people will definitely have breast cancer in our country. 1 in 4 minutes, one patient is diagnosed with a new breast cancer. And every 13 minutes, one woman dies of breast cancer. So there is an urgent need because 2.3 lakhs people are diagnosed and we lose almost half of them. Why? Because 60% of our breast cancer cases come to us very late. If they come early, the survival is great, or close to 90%. And if they come late, the survival goes down. So today, to discuss to all doctors, all nurses, and the public at large, we have great experts. We have Dr. Sneha. Dr. Sneha Bhuyar is a noted gynecologist from Maharashtra. She has got 33 years experience, and she had been a Foxy chairman in the past of the breast committee from 1919 to 1921. She's also an active member of Indian College of Obstetrician and Gynecologist, down to earth clinician, very popular clinician, and it is her passion now that to go across the country and do some good for the people. She will be the speaker today. She'll be talking about the judicious use of diagnostic tools for early detection of breast cancer. We have two more experts. We have Professor Sangeeta Gupta. Professor Sangeeta Gupta has illustrious academic career, and now she is a professor at Noida College, where it is ESI Medical College in Noida, where she is there. Earlier, she was head of the department in Vasai Darapur. And we have another expert, Doctor is a senior vice president of Delhi Gynecologist Forum. We have Dr. Divya Singhal. Dr. Divya Singhal again has come on this particular platform many times, and she is a senior gynecologist. She had been a past president of Delhi Gynecologist Forum North. She has also had been the national coordinator as far as the breast cancer awareness is concerned, and now she has been made chairman by NIGF to create breast cancer awareness. So these are the two experts with us, and here I hand over the stage to Dr. Sneha Bhuyar for her presentation. Sneha, to you.
Thank you so much, madam, for that kind introduction. Very good evening to all of you. I hope, I'm sorry. I think,
Share your presentation. That's right.
I think the presentation is shared already.
हाँ बस उसको खोल लीजिए.
Yeah.
फुल स्क्रीन कर लीजिए मैम.
Yes. Can you see,
Yes.
madam?
Yes, yes. Go ahead.
Yeah. So, a very good evening to all of you, and thank you so much for the invitation to discuss the screening tools. And of course I'll be discussing all the possible available screening tools, and of course the judicious use. So friends, across the world it has been observed that women depend upon their gynecologists for their problems related to the reproductive organs as well as breast, and by virtue of their practice gynecologists are well versed, not only in the breastfeeding, but also the problems related to breastfeeding, the benign breast diseases, and of course, they are also well versed with the endocrinological problems like mastalgia, galactorrhea, menopausal hormone therapy, and even the hormone therapy for breast cancers. All have been taken care by the gynecologist. So, friends, we all are well versed with all the problems with the breast. That's the reason. To accomplish this, the American Board of Obstetrician Gynecologists has provided guidelines to integrate this training in the postgraduate curriculum. This we feel that this also should be applied to India as well, because even till date, our gynecologists, they are not exposed to such training in their PG curriculum. So we have to treat breast as our domain, gynecologist domain, as far as breastfeeding is concerned, benign breast disease, and of course early detection of breast cancer is concerned. We have the major role as preventive oncologists. So friends, today we have these keywords to be discussed: breast cancer, early detection by screening, and judicious use of screening tools. So all of you know very well what is breast cancer. It's a malignancy that starts in any part of the breast, may it be the milk secreting glands, that is lobule, or the milk collecting ducts. It can be even in the stroma. So it can start in any part of the breast and can spread to the adjacent organ and maybe the entire body. So just in short, this is the anatomy, the side view of the breast, where you can see the milk secreting lobules and the ducts, and of course you have the stroma. And this is just the lymphatic system of clinical importance, where you have the high, mid, and low axillary lymphatics, and of course, the most important, the internal mammary and the supraclavicular lymph node. Friends, as you know that estrogen and progesterone, these are the hormones which are produced by the ovaries controlled by HPO axis. The paradox here is the hormones which are responsible for the feminine growth and development of the breast of women. These are the same culprit which actually predispose the woman for breast cancer. So why are we worried so much about breast cancer? Have a look at these figures. These are the figures from 2018. For every cancer it has been given, but here for breast cancer, every year there is 1 lakh 62,468. This is the figure from 2018, but around 1 lakh 72,000 or 74,000 every year new cases are diagnosed. If you see the incidence, it is 14% for combined, but 28% almost for women alone. And have a look at this figure where you have the graph for age. By the age of 20, the incidence of breast cancer is 1 out of 1681, but by the age of 40, it is 1 out of 69. And I'm sure that's the very reason the screening has been made stringent after 40 years of age. So breast cancer is actually one of the two leading causes of deaths of our women, not only in India but across the globe. Previously, cervical cancer was number one, but because of the exact etiology being known, the HPV vaccination and the widespread organized, screening programs, now it has taken a seat back, and breast cancer has become number one cancer because the exact etiology is not known. There is no vaccination, and till now there is no organized screening strategies. But opportunity screening and mass screening programs definitely have a role. So we have divided this screening into three aspects: risk screening, breast screening, and genetic screening. So risk screening, here you have certain modifiable and non-modifiable risk factors. Though modifiable are the most important for us, but we have to know that you are a woman, that itself puts you at a higher risk of breast cancer, your advancing age adds to the risk. Your family history, your mother, auntie, your sister, siblings having breast cancer, you having your one, breast cancer in one of the breasts, that is personal history, you're more prone for the breast cancer in the other breast as well. Early menarche, late menopause, the wider exposure to estrogen, increased breast density, maybe chest irradiation during childhood, and of course the BRCA1, BRCA2 mutations. So these are non-modifiable risk factors, but where our role comes in: obesity, alcohol, smoking, age at first child, the breastfeeding practices, use of or unsupervised use of combined OCPs, and of course the menopausal hormone therapy, where we definitely have a role. We can modify these risk factors. Now, breast screening, when you should do and how. These are the various organizations: United States Preventive Services Task Force, American Cancer Society, American College of Obstetricians, American College of Physicians, and American Association of Family Physicians. All of them unanimously have accepted that for a average risk woman, the screening should start usually at the age of 40 years. And by a minimum difference, they have agreed that 40 to 45 you have to start screening them, recommending them screening, but it can be optional. But 45-year onwards, definitely you should advise them for annual screening. So this is the most accepted and most popular American Cancer Society guidelines, where I would just say that this is the only cancer where you have high risk and average risk. There's absolutely no low risk, because every woman has a 1 in 8 lifetime risk for development of breast cancer, as madam has already given the figures. So you have to start with the breast self breast examination or breast screening, self breast examination from the age of 20, though it can be optional. And of course, breast clinical examination should be done every 3 yearly. Self breast examination, I'll be talking about it a little later in details. Mammography, definitely you must do it annually. That is what is recommendation by ACS. So 40 years onwards, you should go it for annual mammography. And for high risk women, it should be mammography plus MRI every 6 monthly, starting at the age of 30 years, or maybe at least 5 years earlier, to the age of your relative who has been diagnosed or detected with breast cancer. So you have to look for all these abnormalities, that is lump in breast, maybe a dimple, irregularity, scaling, maybe discoloration and nipple retraction, etc. And of course, you have to look for these changes when you are examining the breast. Now coming to self breast examination. So self, naturally the woman has to do it herself, when every monthly during the post menstrual phase, because during menstruation, all of you know that there are certain physiological changes, and you may mistake it for some abnormality. So every monthly post menstrual phase, you have to do it with your own hand. You have to use it, of course, the opposite hand. And how you have to stand or what is the position, you can do it right in front of the mirror, or maybe when you're having the shower. It should start, of course, at the age of 20 years, though it can be observed, it can be optional. Now, about this, though the evidence doesn't suggest reduction in the mortality following breast cancer, but of course, in a resource poor country like India, we have to make our women breast aware. Women are so negligent about their health, and breast, of course, as long as they have some problems, major problems, they don't go to their doctor and don't get examined. Now, self breast examination, you have to expose your breast, or expose yourself up to the waist. Stand in front of the mirror with both the arms by the side, that is first position. Then, of course, rest above the head, and then, of course, on the waist. And then you have to lean forward. So you have to look for the size of the breast, the symmetry of the both breasts, whether you have any lump, dimple, discoloration, scaling, etc. And of course, nipple retraction. Once you're done with the inspection, you have to go for palpation. So I have already talked to you about inspection in all the three positions. When you are leaning forward, of course, when you keep your hands on the waist, you have to lean a bit forward, so that any lump that can be, they can become prominent. Now, palpation, of course, you have to do it with your own hand, that is the palmar aspect. The three finger, you have to hold it firmly, and from the, there's no definite guideline, but the only idea is not to miss any part of the breast, so upside down, right to left, maybe center to periphery, radial, or just circular. So all this way you can go ahead with palpation to look for any lump and bump in the breast, and any thickening also, whether you have any tenderness. After the breast, you go for the armpit, that is axilla, and then of course the supraclavicular area, you have to look for any lymph nodes as well. And then the last step is to squeeze the nipple to look for any abnormal nipple discharge. The same examination, when is done systematically by a clinician or a trained paramedic without using any gadget, it is labeled as clinical breast examination. We've already discussed that you have to do it every 3 yearly, 30 years onwards. So similarly, what I have already talked to you, that same examination done by a clinician. Now, coming to the breast imaging modalities, you have the various modalities, right from the common ones, the X-ray, conventional mammography, digital breast tomosynthesis, contrast enhanced digital mammography, and then of course you have ultrasound, sonography, automated breast ultrasound, and you have whole lot of list which we'll be discussing which one is better. So color Doppler, power Doppler, tissue elasticity imaging, stress elastography, shear wave elastography. Then MRI, diffusion wave imaging, MRI, and magnetic resonance elastography, magnetic resonance spectroscopy. You have gamma radiation nuclear medicine, SPECT and PET. And then you have non-ionizing radiation, that is optimal imaging, breast microwave imaging. So this is just a chart which I'll be only talking about few important points. The mammography is the gold standard even today for screening as well as diagnosis. The sensitivity is wide range, 68 to 83%. The specificity is quite good, 90 to 95%. It can detect the masses, calcification, etc. But the sensitivity, it goes down with the dense breast, and that is the most important disadvantage from mammography. Full field digital mammography, it gives you higher sensitivity, 85%, but the specificity goes down because even the folds of normal tissue can be misinterpreted as a tumor. Only thing is improved sensitivity for dense breast, because it is having a deeper penetration, and even the soft copy can be reviewed once again. It can be used for telemedicine. Contrast enhanced mammography, good sensitivity, but again it requires the injection, so it becomes little invasive. Similarly, breast into mammogram also requires an injectable to be pushed, so it may not be available also at most of the centers. The ideal today, in today's era, you have sonography and conventional mammography, so the combination of both gives you increased sensitivity to 95%, though again the specificity goes down because of increased sensitivity gives you high false positives. Volume based ultrasound and sonomammo definitely gives you improved sensitivity as well as specificity of 99.7%. Dense breast and high risk women, definitely you can subject to volume based ultrasound. Sonoelastography and MRI, as I'll be talking, it is not a screening modality unless and until you find that sono and mammo both are inconclusive. For an average risk woman, you should not subject them for MRI, but for a high risk woman, in fact, it is recommended along with mammography every 6 monthly. PET CT, sensitivity is 96%, but specificity is low, and it is, in fact, usually it is for the follow of the under treatment patient. Definitely, it gives you good image and registration, and of course. This is what we have to actually keep it in mind, that the imaging modalities, you have to make sure if the lady is younger than 40 years and if her breasts are dense, I think ultrasonography is a better modality, And then, of course, you have to combine this with mammography. Now, the recommendation for mammography is 40 to 44 years, it is optional, though we recommend it annually. But 45 to 54 years, it has to be mandatory annual screening. And if there is nothing abnormal, then 55 years onwards, you can taper it down to every 2 years, and then you can continue to perform it up to 75 years or when the life expectancy is less than 10 years. This is ACS guidelines. All of you know about these images, so I will not discuss the interpretation of the ultrasound as well as MRI. So why should we use the DBT? Basically, digital breast tomosynthesis gives you better visualization, especially for the dense breast. It gives you clear margin. It also gives you images to be reviewed and visualization of the fine details. Also, it can be used, for the telemedicine as well. Now, what are the optimal recommendations for? So we just sum up for the optimal recommendation for average risk women, as we have already said, self breast examination starting from the age of 20 years. Though we say it is optional, but definitely 30 years onwards, regularly we have to do it. Clinical breast examination for average risk women every yearly, starting from 30 years. Annual mammography for average risk women 40 years onwards we should recommend. And but for high risk women, it should be along with MRI every 6 monthly or maybe 5 years earlier than the age of the relative who has already suffered for breast cancer. And then we come to genetic screening. So genetic screening should not be done for every patient of breast cancer. The criteria for genetic screening are breast cancer in a woman of less than 50 years of age, that is one, that at a younger age group, less than 60 years of age, with one of the relatives having either CA colon, CA pancreas, or male relative having a breast cancer, and of course a breast cancer of less than 60 years of age woman which is triple negative. These are the criteria for genetic screening. Now we come to what is called as non-touch screening for the breast cancer. So basically, why we have to give a thought of this for this, and of course why do we talk about all this? First and foremost, mammography is painful. It definitely carries discomfort and of course contact. So non-touch screening for breast cancer is actually, they don't require physical contact with breast, and these techniques, they overcome the discomfort, exposure to radiation, and also the operator dependence. So that means you have to just go with the procedure and you get the report which is not operator dependent. So common non-touch modalities, there are various. There are thermal imaging or infrared thermography, microwave breast imaging, optical or near infrared imaging, diffuse optical DOT, it is called as tomography, automated breast volume scanner, AI based remote screening platforms like Niramai, Braster, and Thermalytics. So what is the principle for all this? I'll just speak in short. That for thermal imaging, it detects the differences in the heat pattern because of the angiogenesis and metabolism. The advantage is it is painless, contact free, and of course the radiation free. It is also suitable for young women, especially with dense breast. But the limitation is that the sensitivity is variable. It is 70 to 90%. It is affected by the ambient heat as well and hormonal status. So it can be adjunct but not replacement to mammo. Microwave imaging, cancer tissue alters the dielectric pattern, that is image reconstruction. Again, the advantages are same as we have been talking, but the limitation is that it is got a limited spatial resolution, and it is still experimental. So it is not available for general use. Optical or near infrared tomography, here it is on the light principle. It absorbs light, it absorbs and then scatters to assess the tissue oxygenation as well as hemoglobin concentration within the tissue. It is non-invasive and it is gives you functional or physiological imaging, but the depth of penetration is limited and it requires further validation. It is also still under experiment. Automated breast volume scanner, this is quite promising. Automated transducer scans, it actually scans the entire breast volume, and it is operator independent. It is good for even the dense breast. Definitely, when you are using a ultrasound or scanner, you have to apply some jelly, so some contact is definitely there. So, but the equipment is very costly and it is not available in majority of the center. AI-based screening platforms. AI analyzes, it analyzes the infrared images to identify abnormal vascular pattern. It is completely non-touch, and of course, it has no other side effects. But definitely, it requires algorithm validation. May miss even the deeper ones or even the smaller tumors. Now, for Indian context, what is the latest evidence? We talk about Niramai. It is AI-based thermal imaging technology validated in multiple centers. Reported sensitivity of 90 to 95%, specificity of 80 to 85% in the trials at IIT Madras and BMS Hospital. It is endorsed as potential trials tool for population screening in low resource countries, and it is approved by CDSCO and CE marked Edinburgh University. As compared to conventional mammography, totally it is non-touch, painless, radiation-free, portable, and it is communities friendly. Accuracy is also very good, better for dense breast with and it has got definitely high cost efficacy. As per WHO, ICMR and NCCN, these are the adjuncts to mammo, not replacement. So these are actually the triage tools for community screening, especially the women less than 40 years. How should be the ideal screening test? Now we come to sum up whether we have the entire cafeteria or entire basket available here. How to choose? The screening tools have to be very highly sensitive, not to miss anything. It should be highly specific, not to include large number of false positive, and should be easily available, accessible, acceptable, and totally non-invasive. There should be effective treatment and of course effective referral. It should be cost effective. So friends, self breast examination, clinical breast examination, and imaging modalities like mammography, these are the tools which can be used, or rather which should be used for community or mass screening at present. What is the future of this? Mammography is the gold standard till date. Not it is non-touch thermal, infrared, or even the microwave and optical tools, these are just the adjuncts, not replacement till date, because some of them are not available and some of them are not validated. Integration of AI plus thermal plus ultrasound hybrid systems like automated volume breast scanner, cloud-based screening networks for remote interpretation. You may have this available, but you may not be having the interpretation which is standardized. So there should be cloud-based screening networks. Large-scale trials for validation in population mass screening programs. This ICMR, it is going on. So I think. AI will definitely have a role in future, if at all we combine the old methods of mammography along with the hybrid systems of ultrasound. This is the chart where actually we have what minimal should be available, what optimal, and what is the highest level of care. So for primary screening methods, at least clinical breast examination should be performed regularly. So clinical breast examination, in all three places we keep it as, even in the high resource situation or a high resource settings, clinical breast examination should be performed. It should be performed, yes, ideally by a breast surgeon or a clinician, like what we are talking about, we as obstetrician gynecologists, yes, definitely. But if not available, at least by a trained primary healthcare worker or trained paramedics. What should be the age for screening? 40 to 65 years. And then this is minimum, but definitely ideally what we have been talking, that clinical breast examination from 20 years onwards, and the regular breast mammography, it should be also from 40 years onwards. Frequency of screening, it should be ideally, according to American Cancer Society, it is annually, but yes, if not so, at least every 2 years but not minimally, at least 3 times in a lifetime. So, friends, are we really vigilant enough in screening our women or screening ourselves? No. So, I would go a step ahead and say that why blame governments only for not having organized screening strategies? As a responsible citizen of India, it is our moral duty to look into the matter and do whatever we can do. As gynecologists, we are privileged that every woman come to us for whatever their problems, whether they are it is related to their reproductive organs or breast or maybe whatever. So we have to utilize this window of opportunity, explain them the importance of the examination or the screening, and go ahead with the screening. So you try to examine the breast of each and every woman, and if at all you find any abnormality, you evaluate them further, and you do the timely and effective referral. If at all she doesn't have any problem or abnormality, you teach her self breast examination and ask her to report to you or any doctor if at all she finds any abnormality in future also. I'm sure ASHA workers and Anganwadi Sevika, these are the basic units of our healthcare system. If at all we train them in this, definitely I'm sure they're going to do justice to this, and we will definitely succeed in early detection of breast cancer, and definitely make our women breast aware. Early detection not only saves lives but also saves breast. That is what is our slogan now, because if at all the malignancy is diagnosed early, you can go ahead with the conservative breast surgery, and the quality of life also can be improved. So with this, um, I conclude my talk, and once again I thank all of you for your patient listening, and of course for the opportunity. Thank you so much once again.
Wonderful, Sneha. I will request now my two experts to chip in, Dr. Sangeeta and then to Dr. Divya. Sangeeta.
It was
Keep your comments very
beautiful.
short because we have only
Yeah.
10 minutes to wind up.
So it was very beautiful and to the point presentation, Dr. Sneha. And
Thank
what exactly judicious means a balance
Yes.
between the screening and the harm of the screening, which may be overdiagnosis or anxiety to the patient. So, what I would like to highlight is the proper counseling and communication which should be there with the patient whenever we are doing a screening process and discussing the result of screening with the patient. It should be properly counseled and communicated. Secondly, it's not the number of screening tests we are performing, it is the quality also of the screening test which we have to focus. That means our technicians, our radiologist, our machinery, our reporting system sending to the patient, which is very important. This all has to be streamlined and perfect. You have already focused on the training of ASHA workers and ANMs, which are our grassroots workers. They should be trained in clinical breast examination, and we all have to be screen smart. It has to be targeted, it has to be evidence based and individualized. Every no size fits all the persons, so we have to strategize it based on the high risk behavior, the high risk behavior, family history, as well as personal history of the patient. So I think this completes the cycle of screening. Thanks a lot for making me a part of this. Thank you.
Dr.
Thank
Divya, before you make a comment, there are questions, from the common public. How do they, when they get the report of imaging in Virad 1 to 5, what is your strategy? Just tell them in a very simple way.
Ma'am, is this question for me?
Yes, आप जब करेंगे तो इसको भी जरूर लीजिएगा.
So, good evening, madam, and thank you for giving me this opportunity. BIRADS, सबसे पहले, initially, we must know about BIRADS 0 because that is the most important and most ignored. We feel BIRADS 0 report means that nothing to be done further. But BIRADS 0 means that they were unable to come to any conclusion regarding the status of the breast, and therefore they want us to suggest advice another modality of imaging. So usually the other modality, if the breast is very dense and she's more than 40 years of age, then MRI is the best. But in case she's less than 40, then ultrasound is another modality which can be used for dense breasts. So this is regarding BIRAD 0. BIRAD 1 means it's a benign, in case there is a lesion, it's a benign lesion, so one can forget about it. BIRAD 2 means that the benign lesion is there, but 2% chances is that it could be malignant. It could be malignant. Now, BIRADS 3 means that it is better to do a biopsy, though it is still benign. BIRADS 4 definitely is malignancy, and BIRADS 5 means that we already know that this patient has a malignancy, a breast malignancy, and we are just following her up with a mammogram.
My suggestion to you is that, when you say that Brad one, one should say just forget about it. You say that most things are normal, but always keep that particular patient and a follow up. Now,
Yes,
many people have an idea of, if there's a breast pain, they come rushing, and also the public feels if any swelling does not have a pain, it is not cancer. So, आप उसके बारे में भी थोड़ा dilate करें.
yes, ma'am. Yes, ma'am. This is a wonderful actually question, because most of the people, when they feel there is pain in the breast, then they fear cancer. And that is the time when they come to us. We must understand that usually pain in both the breasts does not mean cancer. It is usually fibrocystic disease. It is usually cyclical or non cyclical mastalgia, which needs a little bit more. Of course, the clinical breast examination, the history taking, and one imaging modality, maximum an ultrasound breast, to confirm our diagnosis. And of course, now,
If there is a pain and lump, what will be your strategy? What will be your advice? Before she goes for imaging.
yes, ma'am. So, in case there is a pain and if there is a lump, then usually they are either maybe if she's lactating, it could be a breast abscess, a lactational breast abscess. It could be a fibroadenoma. Usually, fibroadenomas are non-tender, no, are painless. But these are the usual, or a fibrocystic disease of the breast. So, but
Dr.
in
Sneha, any comment by you? If patient has a pain and patient has a lump, she has come to you. Will you pass it off as benign and forget about things?
No, no, no,
No.
definitely, definitely. If it is basically, we have to see if it is of short duration. Maybe initially you try and counsel her, give her antibiotics, anti-inflammatory, hot fermentation, ask her to review. But definitely, you have to give her a warning that we have to follow her up and we have to make sure that this disappears completely, or maybe she doesn't have any residual lump or abnormality and she needs to go for imaging also. The
Yes.
whatever imaging is, of course she must undergo, because to be very sure, nowadays even we are telling imaging for fibroadenoma as well, correct? Previously we used to say young girl, 20-year-old, you are clinically, you are sure your clinical acumen, but no, for documentation and to be very sure, and of course you have to have some documentation for follow up in future, you must undergo or advise her for imaging. That's
Dr. Divya, people come with a lot of nipple discharge. What should be your strategy, for lay public who's listening you?
yes, ma'am. So, for nipple discharge, we must remember that if the nipple discharge is coming from a single duct, it is spontaneous and it is serous, then it means there could be a malignancy. If it is coming from both the nipples, bilateral, and if it is milky or it is greenish, then there is nothing much to worry about. Of course, we will go ahead with to confirm with an ultrasound, but the main thing is single duct and unilateral nipple discharge, which is serous or bloody, that means blood stain, and it is coming out itself, spontaneous. Then we need to worry, we need to get our MRI done to find out what is happening inside.
Now,
I
patient,
think
I want your Dr. Sneha to make a comment. Patient comes with any of the breast symptoms. How are you going to assure her that everything is all right?
yeah, basically, whatever symptoms she has, like whether it is pain, whether it is nipple discharge, or whether it is anything else, we have to make sure whether it is associated or accompanied with lump. That you have to make sure whether it is accompanied by some lump also, that you have to make sure. And then the, the modality of evaluation also changes. If it is not associated with lump, then of course the symptomatic treatment, and then you try and rule out one lesion. That is how it should go.
I,
Definitely any lump. Yes, yes, madam.
the way I look at things, whenever a patient has come specifically to you for a breast complaint, beside
Hmm.
clinical examination, imaging तब जरूर use करनी चाहिए
Yes,
if
yes.
patient is more than 40 years.
Ma'am, to this, I would like to add something.
I think
Yes.
that is a window of opportunity we should utilize. That is what, in fact, we say that the moment, the very fact that she has come to you for, whatever her complaints, that is what we look at it. If she has some complaint, definitely she needs to be subjected. But otherwise, also, if she doesn't have any complaint, I think that we should utilize the window of
we
opportunity.
we we gynecologists are very fond of saying that ठीक नहीं लग रहा, सब कुछ ठीक लग रहा, 3 महीने के बाद आना. What will you comment, डॉक्टर संगीता? 3 महीने के बाद आना. 3 महीने के बाद इज किलिंग.
No.
नहीं डॉक्टर साहब,
We,
आप अपनी आवाज को
we,
करिए, अनम्यूट करिए डॉक्टर संगीता.
This is wrong. We should take the action immediately and we should do the proper testing of the patient and proper advice screening procedure, because we try to forgo the things, time pass karna chahte. And Dr. My another message is, whenever in, I can talk about the government hospitals with majority of low resource setting patient comes, whenever patient comes as a tells us, madam मेरे को breast में ये problem है, we directly refer the patient to the surgical OPD, which is absolutely wrong. We all have to take this point that we have to examine the patient, write our findings, and suggest the things at our end only, because 70% of patient they don't go up, they don't reach up to the surgeon. And आप 3 महीने छोड़िए मैडम, 6 महीने, 1 साल पेशेंट का निकल जाता है, and we just miss the patient. So my message along with the answer of your question is that patient should be listened properly, should be examined properly, should be counseled and communicated properly, and screened and investigated properly, then and then only. Otherwise we are going to lose the opportunity to save the breast.
पहले तो उसका अपने लेवल पे डिले, फिर उसका
Now,
इमेजिंग और बायोप्सी लेवल पे डिले, फिर रिपोर्ट आने के बाद उसके बाद फर्दर डिले. तो आई थिंक
so
ऑल दिस पर्टिकुलर डिले आर मेकिंग, डेफिनेटली यू फाइंड साउथ इंडिया में क्या फर्क है. साउथ
yes.
इंडिया में देयर इज एन अर्ली डायग्नोसिस, सो द रिजल्ट्स आर ग्रेट. हमारे यहाँ
yeah.
लेट डायग्नोसिस है फॉर वन रीजन और द अदर, सो वी हैव प्रॉब्लम. नाउ आई थिंक वी हैव नो टाइम, वी विल लाइक वन सेंटेंस ईच should be spoken. Sneha, to you, and then Sangeeta, and then Dr. Divya.
Yes, from my side, तो madam, I would say that it should
डॉक्टर
be.
साहब, आप ये जरूर क्लियर कर दीजिए कि ये जो जेनेटिक काउंसलिंग की आप बात बताई है, ये
Mhm.
कितना प्रेवलेंट है, 5 to 6%, और एक बार इसके बारे में जरूर लोगों का मिथ
Yes,
क्लियर
yes.
कर दीजिए.
So these are called as familial breast cancer. That is one. So familial breast cancer, they are hardly 3 to 5%, and inherited breast cancer, though, or family associated, they are almost 10 to 15%. So if you have some family history, whether it is breast cancer or maybe ovarian cancer, colonic cancer, or pancreatic cancer, or a male relative having breast cancer, definitely you should go for evaluation, that is genetic evaluation. Definitely these are the familial and inherited, both the cancers need genetic evaluation, that you should. So but we have to look it from the other angle, I would say, because they are only 10 to 15%, rest 85% are non familial. So you have to make sure that every woman has 1 in 8 chance for breast cancer. So every woman should be looked or investigated or examined and screened as high risk. That is what the message I would like to give, because considering the 1 in 8 lifetime risk of breast cancer, we have to consider every woman as high risk for breast cancer and utilize the window of opportunity. Whenever she comes to you, please examine, get her evaluated, and have the basic documentation. I think
Dr.
that should.
Divya, people are listening to you. They get confused now. Gynecologists mean breast cancer, but there is a triple A negative or HERS2, you want to make a very simple thing how the therapy changes and how the prognosis changes.
Madam, question for me. So, when we get the immunohistochemistry report, the biopsy report, it tells us whether it's an ER positive, that means estrogen receptor positive, progesterone receptor positive, or HER2 positive, or triple negative. So, which means that if she's estrogen receptor positive, if we give an anti-estrogen therapy to her, she will respond. Similarly, anti-progesteronic therapy will respond to PR positive. But triple negative means she has no hormone receptors which can be treated, which can receive the targeted therapy. So this is the most aggressive cancer, and this with hormones we cannot treat triple negative. So one has to be very very careful about the knowledge. So to this, ma'am, I just wanted to really
No, I
add
just want to
something.
tell you what she
So,
is
so
highlighted is
also,
our younger people are getting more cancers. Ours is 20 to 25% in comparison to the Western, where it is 5%. And triple negative are becoming more common in this,
More
and
common.
they are younger, they are aggressive. And that is why one should, younger people, once they have something related to breast, they should not sit over for days together on this. They must go to the doctor and get themselves examined.
Madam,
So I think,
very important message. Yes, because earlier we used to believe that 40 plus we will start examining patients, but now we are seeing in India and Asia that younger patients are getting cancer, and to the rate of 20%. So we have to be very, very careful with 30 plus patients also. Any lesion of the breast, unless proved benign, should be taken carefully, whether she's a 20-year-old girl or a 50-year-old woman.
Sangeeta, comparing to the southern India and North India, because people are coming late, what will be your last tip to them?
My message will be that in North India, the quality of the standard of living of the patients is poor. So clinical breast examination and self awareness program are the key to the diagnosis, screening and diagnosis, and we should focus on then on every grassroots level, as well as proper documentation of the screening findings, and follow up is mandatory. We just do the screening, we just say that it is done, and then we forget about the follow up of the patient. So follow up of the patient is equally important, and clinical breast examination and awareness, that is self breast examination, I will call it more of awareness about knowing their own body.
Right.
So it
Yeah.
has to be highlighted. That is my
One
message for
last request to everybody who's listening, whether they are gynecologists, whether they're nurses, I think high time has come that every gynecologist, whenever the patient comes, should have to do
yes.
opportunist breast examination, and this should not be forgotten. I think they should teach their nurses also to do a clinical breast examination, and I think with that with great training, if they can do wonders as they are doing in a down south situation. And people are even thinking of training आशा वर्कर्स ऑल्सो फॉर द
yes,
सेम.
yes,
कुछ
that
तो
is what.
चीज जरूरी है, वो एक बार पता चल जाएगा कि कोई भी ब्रेस्ट लम्प, कोई भी ब्रेस्ट पेन, कोई भी निपल डिस्चार्ज में घर नहीं बैठना है, आपने जाना है, because this
Uh,
is going can be a cancer for you. So I think with that, thank you very much to each one of you.
yes,
Thank
all of
you.
us
Thank you.
played
Medicine
right.
Room.
Thank you, Arpita. Thank you.
Thank you so much,
Thank
ma'am.
you.
Thank you so much, all the doctors. Thank you.
Thank you very much.
Thank you.